please.
All right, good morning. Let me just see if I can even see myself. I might be muted. One sec.
No, we can hear you.
Okay, good. I just can't see myself, but that's fine. I don't need to. So I'm sure some of you are surprised to see my name associated with this title, myself included. I don't give a lot of presentations, so after I volunteered to tackle this topic, I did ask, what have I gotten myself into? For a subject that people devote years of study to write books and dedicate careers, I'm hardly qualified. However, what I do have to offer is that I've been around for a long time and I observe things. So for such a broad topic, I thought I'd like to keep it focused from my perspective as an interventional cardiologist. And I'd like to specifically look at the triage list for cardiac catheterization. And so I think I'll present a typical case, and this should highlight the issues. Mrs. JL is a 71-year-old woman from Miramichi, and she awakes with chest pain on Friday, January 20th. And so we're going to call that day one. She is hospitalized and diagnosed with a non-STEMI. Her ECG shows 1 millimeter of infralateral ST depression. Her troponin peaks at 5,234. A referral is put into cardiac triage at 5:30 p.m. that same day. So the referral documents would not be taken off the fax machine until Monday, January 23rd, and then ultimately a bed becomes available on the 5B North transfer service on Sunday, January 29th. So that's day 10. She'll go on to have a complete history and physical, as well as a discussion of informed consent for a procedure on January 30th. And ultimately, cardiac cath is performed on January 31st. So that's day 12. And I've put a caret on for the results. She does have anterolateral and apical hypokinesis. Her ejection fraction's mildly depressed at 45%. And I've highlighted with the 3 red circles the critical lesions. So her proximal LAD is occluded, but that's chronic. She has an obtuse marginal branch on the right of the screen that's rather large, and it's got a proximal 70% stenosis. It's her distal right coronary artery that has the culprit lesion. It's an ulcerated 90% lesion. But part of the problem is there's just diffuse 50% disease proximal to that stenosis. So she'd be taken off the table. She'd go back up to 5B North, a consultation with the on-call cardiac surgeon would take place. And so in-house bypass surgery is recommended, and she's informed that it'll occur next week. The tentative date, Tuesday, February 7th, puts her at day 19, but ultimately an unstable patient down the hall in the step-down unit postpones her surgery, and she ultimately gets the surgery done on Thursday, February 9th, and that's day 21. So I'd like you to keep in mind that what I've just presented is a kind of bread and butter, straightforward case with no complicating issues. I could have added comorbidities, frailty issues that might prolong or delay for surgery because consultations need to occur or other pre-op investigations. And so if you look at this woman's clinical timeline, it would look like this. So day 1 is, oh, sorry, I'm getting texted. Day 1's when she presents to the emerge. Day 10, she comes to St. John. Day 12, she gets her cath, and day 21 is her surgery. And 21 days is a long time to wait. And it's not just her that's affected. She would have family members who have to take time off from work. They'd be paying for hotels, driving back and forth. And this doesn't even include the post-op period. So in this talk, what I'm hoping to look at are ways to shorten some of the gaps. And I'll talk about innovative ideas that have evolved in the NB Heart Center over the years, and hopefully offer some thoughts on what we could try in the future. So access to the cath lab can be viewed in two patient populations. There's the inpatients and outpatients. And all inpatients, for intensive purposes, come through our emergency departments, either locally or from the rest of the province and PEI. And at 80%, the bulk of our inpatient cath populations do come from away. The ones that come direct from the emerges to the lab, those would be the STEMI population. Otherwise, you would be admitted to a CCU, a step-down unit, perhaps another service like ICU, internal medicine, family medicine, and then referred on for cath. And for the outpatient group, they would be referred by a cardiologist or internist to cardiac triage. And this is where all the magic happens. And just up in the upper right-hand corner, I've circled in yellow, Carrie and Mackenzie wanted me to bring notice to the kind of burgeoning packets of new referrals that fill a wall organizer throughout the day. So a two-page form and a physician's dictated letter are necessary to ensure the procedure is indicated and to avoid unnecessary transfers or travel. Now, fortunately, it doesn't happen often, but we will get patients and family members showing up in the outpatient clinic without any idea as to why they've been referred. And after further discussion, it becomes quite clear that this is really not the right test at this time. So I think it is a testament to the efforts put in by the access coordinator and triage that the screening put in place works. I think it's, if we were canceling multiple caths every day on a daily basis because of poor screening, our wait list would be insurmountable. So triage is staffed Monday to Friday, 8 to 5. 2 interventional nurse associates take turns on a weekly basis. But it is a team effort, including admin support staff behind the scenes as well. A transfer service cardiologist, so one of the 8 of interventionalists, oversees the list. And sometimes a telephone discussion with the referring physician is necessary to make sure that this is the correct investigation. So to give you some perspective on the numbers we're dealing with, I've outlined some data from our last fiscal year between April 2021 and March 2022. The OPCC evaluated 1,366 outpatients. Our wait list stands between 129 to 161 patients per month, and that is an astounding improvement compared with the days before our third cath lab was created in 2006. At that time, we had a wait list well over 500 patients, and it was so bad that referring physicians were admitting their patients to hospital following a stress test with the hope that they could get their patients to St. John quicker as inpatients. So 2,623, that would be the number of inpatient referrals for all of New Brunswick, as well as PEI. 2,222, that would be the number of just diagnostic cath procedures. Now, if someone had a diagnostic cath and a stent at the same time, that adds up to 1,514. 361, those would be people that have a cath, they're taken off the table, they're seen by surgery, but ultimately they come back for a PCI. And so if you add up those last 3 numbers, that gives you a grand total of 4,097 procedures that we did in the last 12 months. I would like to highlight some of the efficiency strategies that have been implemented over the years. So our administrative director, Jeanine Doucette, has been with the Heart Center since day one. She was a nurse associate and then took on the role of access coordinator in 2005, and then took on the role, her present role as director since 2009. She and Dr. Paddock were instrumental in creating a triage process that ensures equality, fairness, and transparency in providing access to services. Utilizing a TIMI risk scoring system is just one method of keeping the vast amount of data the triage office deals with organized and efficient and objective. We have to ensure that the patients who are at greatest risk of suffering an adverse event receive access to the Heart Center services first. So the STEMI program, created by Dr. Barry in 2009, was initially piloted with the George Dumont Hospital. STEMI patients arriving to their emergency received thrombolytic therapy and then immediately were transferred to the Heart Center for further investigation and treatment. The DRIP and SHIP program achieved rapid success that was quickly disseminated to the rest of the province and also includes PEI. It's hard to believe, but before the program was created, we would expect referring centers to wait 90 minutes after the administration of lytic before making a decision for emergent transfer. And so it's not surprising patients were having worse outcomes. Our partnership with Ambulance New Brunswick has been important, not only for their expedited transfer of patients to St. John, but also getting patients back to their referring centers ensures that we have available beds to accept sick patients coming down the pipeline. Along these lines, communication with Ambulance New Brunswick regarding the patient's clinical status and real-time ECGs has been another area of improved efficiency. In the past, decisions regarding activating the cath lab were based on the patient's evaluation once they arrived in our CCU. Now, if the patient's nearing Norton, New Brunswick or Welsford, depending on which part of the province they're arriving from, and has not obviously reperfused, we will activate the on-call team and direct Ambulance New Brunswick to go straight to the lab. So back to the timeline from the initial case, we have been able to shorten the transfer time from referring centers to the Heart Center with the IPOP program. Select patients in Moncton, Fredericton, Charlottetown, and Summerside no longer have to wait for an inpatient bed to become available. They arrive direct to the lab by ambulance. They have their procedure. This usually includes PCI, observation in the holding area of the lab, and then transfer back to their referring center with discharge home the following day. Some patients awaiting in-house surgery can wait back at their home hospital until the day before the surgery. Careful decision-making regarding is crucial to not transfer the ones with a higher likelihood of becoming unstable. In theory, this is a service that should be available to the entire province. Coordinating this with Ambulance New Brunswick has been proven to be more challenging than anticipated. So Dr. Lechmedial's contributions to the NB Heart Center are innumerable. His leadership, teaching, research, sense of humor are all greatly missed. His introduction of the radial access upon his arrival in 2000 was landmark. It really put us ahead of the curve for what is now the standard approach worldwide. Not only do our patients have fewer access complications, but it's permitted quicker mobilization, as well as the concept of same-day discharge. Almost all of the OPCC patients can leave hospital following their procedure, and a great many can even return to their home, especially if they live in the southern New Brunswick region. The move of the NB Heart Center to 5D North has been a milestone achievement. It's permitted greater sharing of ideas, collaboration, flexibility, and improved productivity. The creation of the TAVI program and its evolution is an excellent example of a magnificent accomplishment for the Heart Center. Being able to offer a life-changing procedure to really sick patients who would not ordinarily have been able to withstand major surgery. I think our TAVI coordinator, Heather LeBlanc, and her team deserve considerable praise for improving the efficiency of the workup evaluation. Whereas in the past, these highly comorbid patients would sit hospitalized on 5B North service, waiting for a variety of investigations and consultations. And now it's been largely replaced with evaluations on an outpatient basis. The patients with COVID positivity have been devastating for the Heart Center. Not only are we seeing patients with an increased thrombus burden in the cath lab, but timing of cardiac surgery has become very problematic. COVID has been associated with a significantly higher hospital stay, ventilation time, ICU stay, mortality rates are higher, as are post-operative complications, including stroke, atrial fib, blood transfusion use, inotrope use. So surgeons and cardiologists face a series of difficult decisions to be made since it's necessary to balance the risk between postponing surgery and the risk of operating with higher adverse event rates. Future directions include the digitalization process of the triage system. So there was a brief period between 2005 and 6 where we had a province-wide computer program to input all of the information. However, it proved to be really dysfunctional and not user-friendly at all. So I think there's still too much reliance on fax machines and handwritten forms. It is wonderful that our nurse associates are able to, in the triage office, can provide excellent communication to the referring centers. But it does feel like at times they're spending too much time answering telephones that distract from day-to-day operations. To wrap up, the NB Heart Center should be proud of the achievements and advances that have occurred in the last 30+ years. Great strides have been accomplished in efficiency strategies and enhancing access. Of course, we'll not rest on our laurels. We will continue to be creative and innovative as we improve outcomes in Maritimers' heart patients. So I think for my final slide, I'd like to just leave you with an inspirational quote from Helen Keller. The best and most beautiful things in the world cannot be seen or even heard, but must be felt with the heart. So on that, I'd happy to answer questions or at least facilitate discussion.
Peter, it's Chris. That's great talk. Nice to see some of this historical stuff from someone who has only been here for a few years. Looking at that first patient example you gave us, are there things that you see from a cardiology side that we could do to improve that gap between cath and surgical date? Your perspective, an outsider's perspective from the cardiology side, you might have thought of things that we could do to improve that efficiency.
Yeah, I'll just put up the timeline.
I mean, I think
It is.
often we think of, we need the Plavix to be off, and that ends up being the next week's slate and inevitably involves a weekend. I wonder if we don't necessarily have to wait 5-7 days, if 2 or 3 maybe is adequate. I don't know what other thoughts you might have.
Yeah, I think dual antiplatelet therapy tends to buy at least 5 days for the majority of the patients. I think for the really critically unstable distal left mains, that would be an exception. But no, it does seem like, although that's been the kind of the recommendation since Plavix has become available in the last 25 years, that hasn't really changed too much. There are some other kind of sometimes unique variables, like a specific surgeon that needs to do it if it was a particular case that involved the aorta, or if for some reason it was a minimally invasive procedure, or if it was a redo surgery. I think there's kind of reasons why there are inherent delays that are beyond our control. No, I mean, I think although I've kind of put down on this slide what looks like about a 9-day wait for surgery, I don't actually know what the average is, and maybe I've given an example of that's rather extreme, but I mean, usually as one of the transfer service cardiologists that kind of looks after these people, for the most part, what seems to transpire seems to be fair, and I don't get a sense that there's too many exceptional cases where we're having to kind of put pressure on you to do them sooner. But these things do come up, and I think it's certainly an area of inefficiency that was relevant to the talk, but I don't know if I have constructive answers as to how to improve upon that. If we did shorten the dual antiplatelet therapy to 3 days, there probably would be some perioperative bleeds that would be increased.
I think Dr. Sharif raised hands.
Oh, hi, Peter.
Hi, Sharif.
Hi, thank you very much for that. I mean, obviously, we appreciate the service that we do get. I guess some areas that I always notice a hang up is when there's been a long weekend. Anybody who comes in like on a Friday before a long weekend, I basically tell them, you probably won't get done next week. Like that's the point that we get to, and that one day, really, backs things up. And I know that that's probably a bit more of a controversial one of, should we be, and this happens to other things in hospitals, should we be offering things on a more regular basis on weekends for certain services that are so dependent on these things? And of course, then there comes in the whole resources and so forth that comes along. But is there any approaches to how to kind of deal with those long weekends that come up? Because I find that's probably one of our biggest things. And then my second comment, just to follow up on the surgery one, I mean, a lot of times the surgical date is like, they may have been off for the 5 days, but sometimes it's extended because our next OR for inpatient day is on Tuesday or Thursday. And so there's the specific days, I think, is probably where some of the hang up is. Like, you can't just say the 5 days, okay, we're going to do it, because there's usually not necessarily a spot that's available because you guys have other things that are booked. So that's what I see from our end.
Yeah, thanks for that. I think for the latter point, I may not be the most qualified to comment on what specific days could be given. I think that's something I've observed as well, and that might be a way to shorten that particular gap. And in terms of the first point, that's definitely very relevant. This is no longer a Monday to Friday 9 to 5 type service. Certainly, we do a lot of cases now on weekends, and not just STEMIs. But I think in terms of having a digitalized process that didn't rely on fax machines should make it a more efficient process. It does seem like if you came in and had your forms faxed on a Friday night of a long weekend and not having them picked up till Tuesday, that's a long period. And some of these non-STEMIs are quite sick. If they had associated heart failure or even shock, I mean, those would be people that we would definitely want here sooner. Yeah, no, I mean, I think that's an excellent point, that long weekends and weekends in general, those can be long delays for sick patients. So that's certainly an area that could be improved upon.
Yeah, and it doesn't really even just have to do with the sick person. Obviously, the reason why some of these people are waiting is waiting for their cath, right? So it's just to move flow elsewhere in the hospital can rely on getting that person's cath done so that then they can go home, so that then the person who's sitting in the emerge can actually get a bed. That may not have to do with the heart, at least in our institution, but you know, so that also plays a factor. So I don't know if there's any thoughts about running like a regular. I mean, I know that you guys have done it on a few occasions where you've run like just a bunch of cases during a weekend day, you know, because of such a big backup. But I'm just wondering if that should become more of the norm as opposed to the exception to the rule.
Yeah, I get a sense that when the wait list, the inpatient wait list gets to around 30, that seems to be the point where we start having to create these days on Saturdays or Sundays where we're trying to do more cases. An extra team is created, and it's a bit of a release valve. So it's true that we don't do it often, but and maybe it's only a few times a year, but that does seem to be kind of a coping mechanism to deal with these periods when we've got really excessive wait lists. But yeah, I guess over time I could see that happening more often, once a month type of thing, and that does definitely, it's a short-term measure, but it possibly is not feasible on a regular basis.
Any other questions? Please chime in. Or raise hand. Okay. It's almost 8:30. Dr. Fong, thank you so much for excellent presentation. It was very, very informative. Thank you, everyone. And please have a good day, and please join us next week for our next rounds. Have a good day.